But we've reached a point in our program where we've had an incredibly thoughtful and rich discussion by our panel of experts. I think a number of topics over a wide spectrum as it relates to childhood vaccines and the schedules for children. We touched a little bit on adolescents. We touched a little bit on adults in terms of seasonal flu vaccines and pregnant women. Some of those issues have been discussed. But even with this sort of very rich discussion, I'm sure there are numbers of issues that we didn't get to. I know we have a large number of people on the phone by Webinex. So actually, if I may ask the audience who is physically present here's indulgence, why don't we start with the WebEx folks and see if there is a question from WebEx, and then we'd be very happy to take questions from the audience here, and we can maybe go back and forth. So is there a question from our participants who are on WebEx? Okay, good. So while they're getting ready, while they're fixing to put their questions together, let me turn to the audience, and I'll ask you to come to the microphone and just again to add to the richness of the conversation, to ask folks if you could identify yourself and what brings you to this particular symposium. I'm actually going to just wait for a minute because I'm sure there are questions since you all made it here on a Monday morning. See, I knew. Yes, ma'am.
Yes, my name is Brenda Wilson, and I work with George Washington University's GW today. Okay, and it's a pretty open-ended question. I mean, I would say in the 50s you didn't hear a lot about autism. So part of, I think, is what's confusing to people is, where the hell did this come from? And I understand that you don't know what is causing it, but since it didn't seem to exist before or it hadn't been identified, and I'll just tell you one quick story, and that is, having reported on vaccines in another life, some people are very fatalistic, and all of a sudden, they're vaccines, and I was talking to one parent who said, well, it used to be in the old days, children just died if something happened to them. It sounds pretty horrible, but it's from, you have to understand where they were coming from, I guess. And she says, now the child may survive, but these children that survive are not as healthy as the children that you keep alive with vaccines, are not as healthy as the children. God didn't mean for them perhaps to live. Man is trying to play God. And one last story, and then I'm going to go away. And that is on the question of trust and the internet. If people who are being mandated to get vaccines read about people in Hollywood not getting them, there's this suspicion that they're being used to test the vaccines. So I'm just saying there's a wide range of reactions. There are different issues of trust even among different communities. So I guess the first question initially is, where did autism come from? Now we've got 50 different varieties of it, and
right,
and no one can tell them why.
So, Brenda, I think that your second question raises a very important and specific point about trust in government as it relates to medicine, medical care, and medical research. And having spent 19 years at the University of Alabama at Birmingham, being very, very familiar with the Tuskegee effect, where, in fact, there was government-sanctioned experimentation on a group of human beings, is very sobering. I think that there are reasons for certain groups of people to not be trusting. But I'd like, if we could ask the panel to address your first question, because I think it's hugely important. And people say this all the time. I mean, as medicine advances and we can tease out these different groups of of disorders that we used to lump all into one. I mean, cancer used to be one disorder. Everybody knows cancer is not one disorder now. Neurodevelopmental issues used to be one disorder, one or two or three sets of disorders. And we know that's really not the case now. And so the idea of how do we respond to people who ask the question, where did this come from? And the corollary question, does it mean that we're having children who wouldn't have survived before, who are now surviving, and that's why we're seeing this? I don't think that's the answer. But let me turn to Kevin to ask for an expert's opinion on this.
Sure. So autism was first described in 1943 by two different Austrian doctors. And that type of autism was what we now think of as very severe, profound autism. So autism combined with intellectual disability. All evidence suggests that it existed well before that. You know, examples in history, different characters in different literary pieces, even descriptions of people who are autistic-like, you know, dating back to the Bible certainly and before. So it's always been with us. It's always affected every ethnic and socioeconomic group. We've gotten better and better at identifying it. Back then, you know, in the 40s, 50s, and even into the 60s, people with autism were generally lumped into those with other intellectual disabilities and generally kind of shipped off out of sight from everybody. And that's the way even extraordinarily prestigious families handled, you know, especially prestigious families, handled children with autism. But there have always been people with autism. Now we're getting much better at diagnosing it, and it's a misnomer to say we don't understand what causes autism. You know, what we know now is that a set of genes leads to differences in brain development, mostly around the formation of synapses very early in fetal development, which leads to a fairly predictable pattern of behavioral disturbances, starting, you know, fairly soon after birth, but then manifesting most strongly around 2 to 3 years of age when the social demands on a child are very, very hard. So we understand an extraordinary amount of what causes autism. One of the greatest risk factors for autism is prematurity. Mm-hmm. And so you make a very good point around the fact that one of the reasons why the rates of autism have increased is that we've gotten very, very good at keeping premature infants alive, as well as being very, very good at keeping mothers alive during childbirth. You know, I can't even begin to address the whether or not God intends for such things, and I just don't care. I hope I'm not offending God that might or might not exist, but you know, I think it's important for us to do everything we can to help those individuals develop as productive of a life as possible. But the two important things are we understand a lot about what causes autism and what doesn't. And it doesn't look like vaccines cause autism. And we are doing a much better job at keeping people alive and giving them opportunities, but we're also doing a much better job at educating people. The world is cleaner than it's ever been in human history. You know, pollution is down, all kinds of great things that are coming out of science. And so, but your broader point of unintended consequences is one that's very important.
The other thing I would add is I think we sometimes don't realize that thanks to the success, I think, this is Breast Cancer Awareness Month. I think that campaign and that effort, I think, has taught and inspired a lot of people who have been affected by other illnesses and conditions that they can take steps to increase awareness. And so I think you've seen in the last 2 decades lots of people who have tried to make a concerted effort to raise our awareness of a whole bunch of medical conditions and illnesses that we otherwise would not ever have known about.
So in Washington, D.C., in the month of October, there is at least 2 walks every Saturday and Sunday for different medical causes. And the point is to raise money for research, to Kevin's point about understanding basic mechanisms, and to increase awareness so that people will come forward to go through certain screenings for certain kinds of disorders, to seek treatment, but most importantly, to have hope. So I don't think it's that it came out of nowhere. I think to really punctuate Kevin's point, it's always been with us. We have shunned those people in our society into institutional settings because we didn't know what else to do, and that's why the general public didn't know about certain things. People with, for example, cancer or mental illness were kept privately at home, and families tried to cope. And I think with awareness, increased acceptance, a decrease in guilt because your family's affected by these things has brought all of these issues more to the fore so that we are now more aware. It's not that something has sort of just dawned on us. And I think that's an important, very important point. So thanks for your question, Brenda. Barbara, is there a question?
Good morning, panel and Dr. Lisa. We have actually a question from our webinar. Our Virginia Science and Technology campus has a group watching this morning, and they sent this question for you. What work has been done to educate obstetricians and gynecologists to discuss childhood vaccines with their patients, as they seem to be trusted sources? So if you could speak to that, please.
Anjali, do you have a comment on that?
I think that there's a lot of, I don't know specifically exactly the studies that have been, but there are a lot of efforts to reach parents earlier and earlier, and also around the time of conception, and to reach both mothers and fathers at that time. And so I think a lot of healthy behaviors we're finding out for prematurity. We don't have a lot of understanding of what causes prematurity. There's been many studies, and prenatal care makes a little bit of a difference, but not a lot of difference. And so I think a lot of our research is showing us that even the womb environment, the care of the mother, social supports, some of these things that are happen even before conception and before the pregnancy are becoming important. So I think obstetricians and gynecologists have a large role in that. But I think that there remains a lot of work to be done.
And the CDC is doing some work. The National Center for Immunization and Respiratory Diseases is working with the professional societies of obstetricians and gynecologists, because there is a growing body of evidence that more parents want that information. It's also had to happen as a result of pregnant women, vaccines being recommended for pregnant women. So that has also changed the field and brought more conversations.
John?
Can I add to that, though? We do lots of disease-specific surveys, and we usually compare what the healthcare practitioner is saying and seeing with the patient. The patients always want more information. They don't think they get enough time. They want some more detail and so on. The physicians frequently agree they'd like to do that, but you know what? Nobody pays them to do that. What they'd like to do is be paid for that as part of their practice. So if they could free up the part of their day to do that. And basically the current pay system basically does not pay for information.
So, but we're going to have to change the way we practice, because we are moving from a volume-based fee-for-service to an outcomes-based population. So there are value-based programs now that are being tested by CMS. There are bundled kinds of programs where you capitate a population and you get to save the money between what they give you and what you actually spend, and it all relates to outcomes. And to get to that point, I think Anjali makes a really important point. You know, as medical specialists, we tend to operate in silos. And if there's anything in medicine and science that is a team sport, it's the care of a mother-child dyad and then the child into the lifespan, when they also then become the mother of a mother-child dyad. And I think with not just vaccines, but with things like obligatory genetic testing, so depending on your ethnic group, there are obligatory genetic tests, that the obstetrician needs to initiate that discussion. Cystic fibrosis, there's testing for families, for Caucasian couples who are thinking of having children. And so I think that it starts with discussions about obstetricians saying to families, it's very important before your baby is born, particularly if it's a first baby, to identify a pediatrician and meet with the pediatrician. I can tell you that was a fundamental tenet of my pediatric education more years ago than I care to remember. And I think we're just increasingly building on that because we realize it isn't sort of stop and start, one house to the next, one care provider to another. It's a team and it's a continuum, and I think that will help with our education. Plus the change in our medical system will also, provide the time.
I think what we're really not dealing with in this country, and probably worldwide, is mental health. And mental health is not going to get better until the entire family is involved and the communities are involved. And, we're talking about autism, which has a 1 or 2% prevalence globally. Things like depression, anxiety, we're talking 20%, 30%. And, with mental health parity and, starting to build a healthcare system where we have people that are trained in delivering mental health services, I think by necessity, will have to become a more holistic and integrated system across providers and provider types.
Keith?
Hi, my name is Keith Crandall. I direct the Computational Biology Institute here at George Washington University. And I'm the proud father of 5 lovely children, and have always been, even though I work on infectious disease, I've always been at a loss for quite what to do with respect to immunizations, because, and all our kids are immunized, but they're not immunized according to the normal schedule. I've had fantastic pediatricians who've worked with me, who know I travel with the kids often to foreign countries, who know the prevalence of pertussis and whatnot in the neighborhood, who will help me cherry pick appropriate vaccines to deliver to my children over time. With my thinking is always that, and this is the question, is whether I'm nuts or whether this is really how you do immunization studies. But my feeling is that when you have a newborn and they want to inject this newborn with 8, 10 different vaccines, some of which are sexually transmitted diseases and things like that, you scratch your head as a father and think, wow, is the immune system really going to be able to deal with all this stuff that we're throwing at it? And have they, while they've tested all these individual vaccines, do they really test them in bulk, in the bulk that we're giving them to children today? And if so, is there a difference in either efficacy of the vaccine or in the immune response against the vaccines when you give them in these bulk settings?
So Keith beautifully articulates the point. Too many shots, too frequently, too little, this is just too much. Anjali, we had this conversation, so can I ask you to kick off the conversation?
I guess the answer is yes and no. Yes, these vaccines are highly tested, and the combinations are tested before they're ever issued for large public use. And you can imagine a vaccine manufacturer or a government agency recommending these vaccines and knowing that they're going to be scaled to hundreds of millions of people. So they are widely tested, but also in its first wave of use, that is a natural experiment. And so the government and vaccine, when you get a vaccine, the lot number is written down, the bottle is written down, All of this information is very well tracked. And so we find out pretty quickly if there's an issue with a vaccine, with a particular vaccine, and how widespread it is, or if it's a particular lot, and so forth. So I can only answer yes, they're tested. Are they tested in the kinds of numbers and the kinds of vaccines that would reproduce their overall effects in the population? No, that wouldn't be possible. But as soon as they're issued, they're tracked very well too. So.
But even there, I mean, the things that would be, if they weren't picked up in those clinical trials, would be very, very rare outcomes.
Right.
Because those clinical trials, especially the third stage,
Right.
involve typically tens of thousands, if not hundreds of thousands of kids. And so you would be looking at things that were exceptionally rare before the vaccine was recommended for use.
But those are focused on a particular vaccine, not a vaccine in combination with any others.
Well, the clinical trials will be some, the participants in the trial will be, normal children in the sense that they would have gotten the other things.
Yes, ma'am.
Good morning. My name is Maria Taylor. I'm from Children's Hospital. I work in the clinic at CHC. I'm a very advocate for vaccines. One, I'm 57 years old, and I had the mumps. And I was in second grade, and I still remember that. Two, I've seen a real case of measles in the clinic, and we've had pertussis, 4 cases, in the last 2 months. My question is, autism and MMR, why did they say it's the MMR when you're given the vaccine with chickenpox too? Why do they focus on the MMR? That's the one that causes the autism.
That is linked to the original Wakefield study where, based on a very small number of children, where the parents retrospectively, in children that had developmental issues, they were asked about the vaccine and they recalled getting the vaccine. So it was a very flawed study that's been recanted by all the authors except Andrew Wakefield. And so, but that was the study that really put it in everyone's mind, and we're still feeling its effects.
Just for a historical perspective, I believe the Wakefield study was published in 1998. So it's a relatively recent study that has caught a lot of attention. It's not like some of the things John was talking about with polio in the 50s. For polio in the 50s, you have to go to museums now to sort of see the iron lungs, to see the pictures of the swimming pools being closed because people were terrified that their children would get this devastating disorder. Yes, ma'am.
My name is Julia Painter. I'm an assistant professor in global and community health at George Mason. And I have 2 kids, 3 and 5, and I had them both while doing a postdoc in vaccinology. And I vaccinated both my kids, no questions asked, obviously, but I have a lot of friends who are having kids around the same time who are not scientists, who, as many of you mentioned, had a lot of concerns and just wanted to do the best thing for their children and were highly educated, and some ended up vaccinating and some not. And as a scientist, I very much appreciate your respectful and thoughtful comments about the issues having to do with vaccination, the way you talked about non-vaccinators. We have very high vaccination rates for childhood vaccines. That goes down a lot for adolescent vaccines, but you all talked about non-vaccinators with respect and as parents who just want to do the best for their kids. And what I run across a lot is scientists who have very dismissive attitudes. This is, I've worked in a lot of institutions, at conferences, on Facebook, everywhere. And so I'm wondering from you all, your perspective, how can we do better at a scientific community? Because all the parents I know who don't vaccinate or have questions just want to do the best for their kids, like you said. But then what I hear a lot from scientists is this dismissive attitudes or Jenny McCarthy followers So I think building trust starts with educating scientists as not viewing non-vaccinators as stupid or uneducated or parasites, but as all of you are saying people who want to do the best for their kids. So how can we start with the scientific community? How can we do better there to have that maybe permeate down?
So if I may, this is not really invoking the prerogative of the moderator, because moderators don't have any prerogative, but as a pediatrician, what I would say is that I made the point about the way we're educating our medical students. And so in this time with the explosion of science, we're 13 years in to the time where we know the human genome. And Kevin talked about understanding genes and genetic risk and understanding how genes sort of set up developmental programs and how certain variations in those genes have developmental programs go awry. So that's hugely important that we educate our medical students, because the front line are not the scientists, it's the care provider, it's the pediatrician. But that is now increasingly counterbalanced with the idea that medicine is a pas de deux between science and art. And the art, to get to Glen's point, is communication. And we're doing a better job, I think, of educating our medical students about the importance of communication. And so sometimes people who can be really, really imperious are people who trained at a time where, as Anjali and John pointed out, physicians were always right. You just never questioned them. You didn't question a lot of things. You didn't question the government. You didn't question anybody. And you're talking about a time now where, as Kevin pointed out, we're increasingly encouraging people to question everything, so at the end of the day you feel you did the best job for your child. So the push should be to educate those frontline providers to be respectful, to communicate, to listen to what those concerns are, and not to think of someone who comes in with an opposing view as being oppositional, but being someone who's looking for information and wants it to be communicated in a respectful way that they can trust. Would be my take as a pediatrician. Let me ask the panel.
Well, having spent a lot of time working at the CDC as in communications and media relations, one of the things that we tried to instill in people who are going to be spokespeople on a wide variety of issues was some of the principles of risk communications, which I often hesitate to put that adjective risk in front of it, because I think they're just effective principles of communications. But that said, I mean, if you look at the risk communications approaches, the principles include leading with empathy. And so you have to have true, authentic empathy. You really have to put yourself in the other person's shoes and try to see the world as they see it. So that's one part of it. Another part is acknowledging uncertainty, sharing dilemmas, managing expectations, guiding expectations. All of those things we probably need to teach people are really important components of effective communications. And I think that will help address those things. Because you have to be able to understand what is the other person's concerns, what are their true concerns, because sometimes what they initially tell you is actually not their true concern. There may be a concern behind that concern, and you're going to have to spend some time trying to figure out what that concern is so you can effectively address it.
I'm a political scientist by training, and one of the most breakthrough things from many decades ago was a statement that the power of the president is persuasion as opposed to authority. The potential power of the physician or healthcare practitioner likewise is persuasion rather than the authoritative statement. The question in my mind, to those of you who are physicians, is does a physician view persuasion as opposed to communication as part of their role?
I think that it depends on what stage the physician is at. People who are at the very end of their career grew up in a different time where certitude was really the most important thing, and they were completely risk averse. I think if you go, the school year has just started, the brand new medical students have just matriculated. I think if you look at their curriculum, there is more focused on the art of communication. Glen talked about some fundamental principles, the importance of communication, and the fact that we are children's advocates, and to be children's advocates as a pediatrician, that one has to ally yourself with the parents, not be in combat with them. Anjali, what your thoughts?
So I was just going to say a couple of things. One is that I think that people who are can see both sides need to be more vocal. I think the people in the middle need to be more vocal and have these conversations in a way that both extremes are invited into the room. And also in terms of communication, I also agree with you that we need to be paid for the time to have those conversations with our patients, and we're not in the current system. And so hopefully, as we reduce the number of unnecessary procedures and surgeries, we'll also be able to get back some of that time in terms of actually talking to patients and having a relationship with our patients.
So if I could, we have a question right here. If I could ask the hosts, Barbara, can we do one more question? Fabulous.
Quick question. I'm Trish McDade. I'm a pediatric nurse practitioner in Northern Virginia. We have lots and lots of people of varying ethnicities. So I wanted to address Dr. Pelphrey specifically. We were thinking about doing a telemedicine kind of webinar thing for patients or parents to log in and get information about immunizations and things like that. You talked about an orientation, so what's your thought about using a telemedicine approach? And also, can you address some cultural disparities or ways that you approach some cultural differences in vaccination rates?
Mm-hmm. Yeah, so I think telemedicine would be a brilliant use of telemedicine. And there's no reason why it can't work. I still would want to offer the going from pediatrics office to pediatrics office to provide individual one-on-one contact, but telemedicine will be great for that purpose. In terms of cultural, I think that there's at least two kind of vectors you've got to think about. One is kind of obvious cultural and try to be sensitive to people's differing perspectives, listen to them. Earlier, the question about how scientists can be better at conveying information, conveying the fact that in the scientific process, and as a father of 5 kids myself, I'm always wrong. Every scientist is always wrong and partially right. And so, it's a process. So conveying that can cut across cultures very fast, and also understanding when people want you to be certain, so as being as certain as you can. And then the other kind of vector of cultural differences is the degree to which people trust authority, or what's the norm in terms of their style of communicating. I grew up in the South, and then had a large portion of my career in the Northeast. I learned very, very fast the difference between Southern style of communication and Northern style of communication, and being able to cut across those lines. I think earlier point about leading with empathy is always a valuable one.
Great. So we've come to the end, I can't believe it, the end of a very stimulating, thoughtful, and informative 2 hours. And I see Leo Chalupa, who's the Vice President for Research at GW, and I wanted to ask you, Leo, did you want to make any closing comments?
I'm just glad you're all here.
And that's a really lovely way, straightforward, warm, empathetic, lovely way to end. So why don't we end on that note? I want to thank the panel very much for all of your wonderful contributions and for this really nice back and forth dialogue. Thanks very much.